glare that makes oncoming headlights seem blinding, or bright sunlight that forces you to look away. That's not something you simply have to accept. In a lot of cases, it has a specific treatable cause. I'm going to show you 4 of the most common ones and show you what can be done about each one. I'm Mr. Dilraj Sahota, consultant ophthalmologist in the West Midlands with training from Oxford and Moorfields Eye Hospital. I perform cataract surgery regularly, and glare is one of the most common symptoms that's mentioned to me in my cataract clinic. It's often present for many years before it's been properly investigated. 4 causes to cover, and the first one often surprises people because it's got nothing to do with the inside of the eye. If you've been told that your eyes look normal, but you still get glare, then start here. The most frequently overlooked cause of glare is not inside the eye, it's on the surface. The tear film coating the front of the eye is an optical surface in its own right. When it's smooth and stable, light passes through cleanly. But when that film is thin, uneven, or breaks up quickly in between blinks, as happens in meibomian gland dysfunction and dry eye disease, it creates an unstable, irregular refracting surface. Think of it as looking out of your car windscreen, and instead of being clear, it's frosted or smeared. Light scatters in multiple directions, producing glare, and vision that feels like it fluctuates throughout the day. You may feel you need to blink to clear your vision. Meibomian gland dysfunction, or MGD, is extremely common. Studies suggest that it affects a significant proportion of people over the age of 40, but the prevalence varies depending on which populations are looked at and which studies you examine. What the evidence does consistently show is that it is regularly underdiagnosed. There is a useful self-check. If you feel that your vision is good sometimes and the glare varies throughout the day and your vision clears on blinking, it's very possible that an unstable tear film is the cause. This is treatable without surgery. Ask your optometrist for a tear film assessment. Warm compresses and ocular lubricants that are preservative-free are the established first-line therapy. I covered both in detail in my last video on watery eyes, and that's linked in the description below. Cause 1 is on the surface. Cause 2 and 3 are inside the eye, and they each produce glare in a structurally specific way. Cortical cataract is the type that is most consistently associated with glare, and it's linked to the structure of the lens. The natural lens has lots of layers like an onion, and the fleshy layer around the inner core is called the cortex. Cortical cataracts form in wedge-shaped, spoke-like opacities emanating from the periphery of the lens inward. So think of it like the spokes of a wheel on a bike. As light enters the eye, it hits one of these spoke-like opacities and scatters within the eye. This causes the glare. It might cause halos or starburst effect around headlights when you're driving at night, and it may give the image a washed out quality in bright light. The clinical evidence is clear. Patients with cortical cataract consistently report glare as one of the main problems, even when the cortical cataract is quite early. Small cortical changes cause disproportionately significant glare, which is why it's worth pursuing a diagnosis even if your general vision is okay. Cortical cataract accounts for 1 in 5 of age-related cataracts. For comparison, nuclear cataract, which is the inner core of the lens, causes gradual dimming of vision, blurring, and changes to colour. Some light sensitivity can occur with the nuclear sclerotic cataract, but it's not the predominant feature, not as intense as you find in cortical cataract. If your main symptom is overwhelming glare from oncoming headlights or in bright sunlight, then ask your optician to look specifically for a cortical cataract on the slit lamp. When glare is affecting your safety or your quality of life, then cataract surgery is an effective treatment and the outcomes are usually excellent. That is cause 2. Cause 3 is a different type of cataract, one that can actually have an even more disabling effect. It's a less well-known type of cataract, and it can affect people in their 40s and 50s and come on very rapidly. If this is useful, subscribe for practical, regular, evidence-based eye health tips. 2 more causes to go. Posterior subcapsular cataract, PSC, sits right before the capsule at the back of the lens. Its precise location within the lens make it quite a disabling type of cataract for not just glare, but for vision overall. Because PSC occupies a central location directly along the path of the light as it enters the eye, it produces pronounced glare and bright light, difficulty reading, and halos around bright lights. Patients often describe feeling uncomfortable driving at night and finding bright lighting intolerable. Unlike nuclear sclerotic cataract, which develops over many years, posterior subcapsular cataract can come on quite quickly, and it has some established associations. Long-term corticosteroid use is the most established association, and that includes any steroid tablets you might take long-term for other medical conditions, or creams around the eye, or steroid eye drops. Diabetes or previous ocular trauma are also well-known associations. And I also see this in patients of mine that are myopic that may develop cataract sooner than the average population. If you or a family member take steroid medication regularly and you're experiencing glare or problems reading, then it's worth an ophthalmic assessment. If glare and diminishing vision are progressing together, particularly if you're on long-term steroid use, then ask for a cataract assessment looking for posterior subcapsular or PSC cataract. Can be quite subtle in the early stages. Do not assume that it's too early or too mild to be relevant if it's affecting your quality of life day to day. Cataract surgery is the definitive treatment for this. Causes 2 and 3 affect the natural lens. Cause 4 is different. It only affects those that have already had their cataract removed. And if you're in that position, I want to make sure you know about this. This is something that I see regularly in clinic, and it almost always comes with genuine relief. If your vision was excellent after cataract surgery initially, and now you're finding that the vision is slowly getting less clear and the glare is returning, that is not your cataract coming back. Cataracts cannot return after you've had the surgery. It's almost certainly something different, and it's fixable. Posterior capsular opacification, PCO. It's the most common complication that happens after cataract surgery. It's responsible for the return of the glare and the haze that patients get after an initially successful operation. When we remove the cataract, we leave the capsule in place. That's like a membrane which holds the artificial lens in place. In some patients after surgery, cells will grow across the surface of the capsule, which is behind the artificial lens, and cause it to cloud over. This typically happens months or years after the initial operation. The cloudiness sits directly behind the artificial lens, causing glare and haziness in the vision. According to data from Moorfields Eye Hospital and the RNIB, around 1 in 5 patients after cataract surgery will develop this within 3 years of the operation. The treatment is YAG laser capsulotomy, which is a brief, painless procedure which is done in the outpatient setting, where we use laser to create an opening in the cloudy capsule and allow the light to go through. There are no incisions, it's painless, and patients usually get vision back within a couple of days. If you've had cataract surgery with good initial vision and your vision has then slowly deteriorated in the months and years afterwards, this could be PCO, so contact your ophthalmologist or your surgical team. Unless you have another eye condition, then PCO is most likely the cause, and it's quite treatable. Before I close, one important distinction. Everything I've covered so far is down to optical glare. That's light hitting the surface or a cloudy lens and scattering and causing glare due to the bright light. If your eye is acutely red, painful, or photophobic, actually sensitive to the light, then that's usually a different cause entirely. That is photophobia, light sensitivity driven by damage to the front window of the eye or inflammation inside the eye. Uveitis, inflammation on the inside of the eye, or a corneal ulcer, which is an infection of the front window of the eye, are the most important causes to exclude if you have photophobia. A red, painful, photophobic eye is not cataract or dry eye. Please see an ophthalmologist urgently. 4 causes of glare, all treatable: ocular surface disease and dry eye, cortical cataract, posterior subcapsular cataract, and posterior capsular opacity or PCO. If glare is affecting your reading, your driving, your daily life, you do not have to put up with it. Please see someone and get it checked. If this has helped, subscribe for regular evidence-based eye care advice. Thank you for watching.